Hi everybody, and welcome to our first module on skin disorders. We'll start by talking about acne. Acne is an inflammatory process that involves hair follicles and sebaceous glands in the skin. So let's talk about what sebaceous glands are. These are exocrine glands that are found in the skin in the dermis layer, and they're called sebaceous because they secrete an oily substance which is called sebum. In addition, the glands that secrete sebum are often connected to hair follicles, so the whole thing together is sometimes called a pilosebaceous unit, meaning it's a hair follicle plus sebaceous glands. And this is a picture on the screen of what a pilosebaceous unit can look like. So you've got a hair follicle and sebaceous glands in the dermis layer. The hair follicle sticks out into the skin, and the sebaceous glands can secrete sebum out into the skin. And this is what gives an oily texture to your skin. Acne has a complex multifactorial etiology, as we will see. It involves hormones, it involves physical plugging of the ducts, and it also involves bacterial growth. Your sebaceous glands enlarge at puberty, and this is why many adolescents at the time of puberty develop acne. The growth in sebaceous glands is driven by androgens, which increase sebum production, and if you know this, then it's easy to understand why adolescent men get acne to a greater degree than women. Women also produce more androgens at puberty, but not to the degree that men do, so acne tends to be worse in men. In addition, men who have androgen insensitivity, which is rare, do not develop acne, and women who have some reason to have excess androgens, for example, polycystic ovarian syndrome, do develop acne. Everything is tied to androgens. You can just remember the A in acne is for androgens. The way that acne develops with increased sebum production is that sebum and keratin begin to be produced in greater amounts. There are keratinocytes that line the hair shafts, and they make more keratin. So the combination of the increased sebum and keratin leads to blockage of the ducts, and then bacteria can grow behind that blockage. So the first component of acne is androgens increasing sebum production and also an increase in keratin production that tends to block ducts. The second component is bacterial growth. So sebum is a terrific growth medium for bacteria, and the bacteria that grow in acne are called Propionibacterium acnes. They are also sometimes called Cutibacterium acnes. These are anaerobic bacteria that are part of the normal skin flora, and they begin to proliferate in those ducts, and that's another component of what leads to acne. So the first component of acne is androgens, the second component is bacterial growth, the final component is inflammation. So the way that inflammation occurs is that comedones allow for bacterial growth. So let's talk about a little vocabulary here. A comedo is a sebaceous duct blocked by debris. This leads to the creation of little bumps on the face. Comedone is a word that means the plural of comedo, so multiple comedos are called a comedone, and then microcomedos are microscopic comedos that are not visible with the eye, only under the microscope. But by whatever term you use, these comedones create a lipid-rich environment for bacterial growth because the bacteria use triglycerides in sebum as fuel. So therefore you get bacterial proliferation, and that is followed by inflammation. So all these elements come together: the androgens, the bacterial growth, the inflammation inside the comedones, and that's what leads to acne. Acne tends to affect the most hormone-responsive sebaceous glands, and it turns out that they are in the face, neck, chest, and upper back. And unfortunately, they're in the face, and this means that many young men who are teenagers develop acne, which can be very embarrassing. People who have acne can have multiple different lesion types. You can read about these in your books if you wish. An open comedo is called a blackhead. This is a cartoon of what one looks like here. So it's open, meaning it's not covered by skin and it's got debris sticking out, and that gives it a black appearance. That's why it's called a blackhead. Closed comedos are covered by skin. They're called whiteheads because they don't look black. This is a cartoon of what a whitehead can look like here. You can also have lesions with pus inside of them, inflammatory lesions. These are sometimes called papules or pustules. And then these can rupture and burst, and that can lead to scarring and hyperpigmentation over time. There are a number of treatments for acne. The most basic one is benzoyl peroxide. This is a topical treatment. Benzoyl peroxide has the structure shown on the screen here. It breaks down keratin, and this unblocks the pores. For this reason, benzoyl peroxide is said to be comedolytic because it breaks down the plugs in those pores. It's also bactericidal to the bacteria P. acnes that causes acne. You can also use antibiotics. These antibiotics decrease the P. acnes colonization of the skin, and therefore there's less bacteria around to grow inside the comedones. Two of the antibiotics that are often used for this purpose are clindamycin and erythromycin. And then finally, retinoids, which are vitamin A derivatives, can be used to treat acne. So let's talk about that now. Isotretinoin goes by the trade name Accutane. This is its chemical structure shown on the screen here. Its chemical name is 13-cis-retinoic acid. It is a version of vitamin A. And in cells, it forms metabolites that bind to nuclear receptors like retinoic acid receptors and retinoid X receptors. And once the metabolites bind to these receptors, it leads to decreased keratin production by follicles and therefore less follicular occlusion, the problem that we talked about earlier. The major clinical issue with isotretinoin is that it is highly teratogenic, and there are many young women of reproductive age who have acne and take this drug. So these women need to take oral contraceptive pills and/or have a pregnancy test prior to starting this medication, because if they become pregnant while taking isotretinoin, there are many fetal anomalies that can develop. Next, let's talk about seborrheic dermatitis. In this condition, red plaques develop on the skin with scale on top of them. The scale basically looks like flaky bits of skin on top of the red lesions. This occurs on the face and the scalp. These are areas that have lots of sebaceous glands. That's why this disorder was named seborrheic dermatitis. The pathogenesis of seborrheic dermatitis is not well understood. There is no inflammation of the sebaceous glands in this disorder like there is in acne. Even though it's called seborrheic dermatitis, that's somewhat of a misnomer because the sebaceous glands are not inflamed. This has been associated with fungal infection by a fungus called Malassezia, which is a normal skin flora. The reason people think this fungus may be involved in the pathogenesis is because treatment with topical antifungals is effective, although there is some evidence the antifungals may actually work by being anti-inflammatory, so it's not clear that Malassezia is definitely the cause. But in any case, the treatment is with topical antifungals, and also corticosteroids usually helps this condition to resolve. Here's a picture of a man with seborrheic dermatitis. You can see these red plaques on both sides of his face. Also, if you look up here on the nose, you can see these little flaky bits that look like skin. That's the scale that occurs in seborrheic dermatitis. Next, let's talk about moles on the skin. The formal name for moles is a melanocytic nevus. These are benign neoplasms of melanocytes. Basically, people who have a mole have too many melanocytes in that part of their skin, but the melanocytes are not malignant. This leads to tan brown pigmented lesions like the one shown on the screen here. They are typically uniform in color, and this is an important criteria because moles that are non-uniform in color may be a melanoma. They are often round or oval in shape, and they are usually less than 6 millimeters. Moles bigger than 6 millimeters are suspicious for melanoma. Some of us are born with these moles. These are called congenital. They're present at birth, and they often have hairs growing out of the lesion. More often, though, what you will see are acquired moles. These appear in childhood. They increase in number during adolescence and peak in the 30s, and they tend to, in some cases, regress as we get older. Rarely, these moles can develop dysplasia and turn into a melanoma. This is a picture of a melanoma on the screen here. I talk about melanoma in the video on skin cancer. What this means is if you're a primary care doctor or a dermatologist and you are evaluating a patient with moles, you need to look for atypical features, because if you see things like a mole that is growing in size or uneven in color or has irregular borders, that may warrant a biopsy or removal to make sure it's not a melanoma. Now, these aren't removed prophylactically for prevention because the risk of turning into a melanoma is relatively low, but they are monitored over time, and this is one of the standard things you do at an annual visit as a primary care doctor, is do a skin check on your patients to make sure any moles they have still appear benign. There are a couple of subtypes of the acquired forms of nevi, so let's talk about that now. Junctional nevi are those that grow along the dermal epidermal junction. These are commonly found in children. As we get older, we often develop compound nevi. These are nevi where the growth extends into the dermis. And then finally, intradermal nevi are nevi that have lost the junctional lesions, and the nevi are found only in the dermis, and this is common in adults. This makes more sense if we draw a picture, so let's do that now. The skin, as you know, is made up of two layers. The upper layer is called the epidermis, and the lower layer is called the dermis. And within the bottom layer, the basal layer of the epidermis, you normally find a small number of melanocytes, and they make melanin, and that's what gives your skin its color. If the melanocytes make too much melanin, that can give you a freckle, and I talk about that in the pigment disorders video. But if you have extra melanocytes growing, that can give you a mole. And initially, these moles tend to grow at the epidermal-dermal junction. So you have extra melanocytes growing along the epidermis where they're supposed to grow, but also within the dermis right at the junction. So you will see on biopsy nests of melanocytes at this dermal epidermal junction in junctional nevi. In a compound nevi, you will have some melanocytes that are at the dermal epidermal junction, but then you will have others that are deeper down in the dermis. This is called a compound nevus. And then finally, in a dermal nevus, all of the extra melanocytes that are growing are found in the dermis. That is a dermal nevus. And these are the three types of nevi. Basically, it has to do with where they're growing, whether they're growing at the junction, and also in the dermis, or just in the dermis. Let's talk about pseudofolliculitis barbae. This is also called razor bumps or shave bumps. This is inflammation of the skin caused by trapped hair. That's why it's often called razor or shave bumps, because it's associated with shaving. What happens is recently cut, very short hairs get trapped within the skin, and this forms papules and pustules in the area of beard growth where men shave. It's very common in black men. Up to 80% of cases occur in black men, and only 3% occur in white men. It basically looks like these little bumps shown here on the screen. It often occurs when men shave on the neck. Moving on, let's talk about psoriasis. This is a chronic inflammatory skin disorder in which patients develop well-demarcated plaques that are usually pink or salmon-colored with a silver-white scale. I'll show you a picture of some of these in a minute. And most commonly, the plaques develop on the extensor surfaces of the knees and the elbows, which basically means on the front of your knees or on the outside of the arm on the elbows. Here's a picture of someone who has psoriasis on the elbow. Note that these plaques are very well demarcated. They are not a deep red, they're a light color, usually described as pink or salmon-colored. And they have scale on top of them. That's this gray stuff that you can see on top of the salmon-colored plaques. This is a classic presentation, classic picture of what psoriasis looks like. The pathogenesis of psoriasis is poorly understood. The disorder is believed to result from a combination of our genes and also things that we encounter in the environment. There's also believed to be a component of autoimmunity, and the reason for this is because psoriasis has a strong association with the HLA-C subtype. In the immunology videos, I talk about the human leukocyte antigen genes, or the HLA genes, and how they make up important components of our immune system. People who have the HLA-C subtype are much more likely to develop psoriasis, and this is the reason that it's hypothesized that there is some component of autoimmunity involved in this disorder. There are a number of classic findings if you biopsy a psoriatic lesion, so let's talk about that now. First of all, you will see acanthosis. This means thickening of the entire epidermis. You will also see parakeratotic scaling. So parakeratosis means retained nuclei in the stratum corneum. It's seen in conditions where there's hyperproliferation. Normally, the keratinocytes in the stratum corneum, the outer layer of the epidermis, do not contain nuclei. In conditions where there's lots of proliferation, you can see retained nuclei. That's called parakeratosis, and that's seen in psoriasis. The stratum spinosum is increased in size. That goes along with the acanthosis, the thickening of the epidermis. The stratum granulosum tends to be thinned or absent. And then finally, a classic finding is a Monro microabscess. This is a collection of neutrophils in the stratum corneum. Shown on this slide is an example of a biopsy from a patient with psoriasis, so let's go through all the findings. First of all, note that the outer layer of the epidermis is increased in thickness. That's hyperkeratosis. This is what is going to give that scale that you see on the skin of patients with psoriasis. Note also that some of these cells have retained nuclei. That is evidence of parakeratosis. The epidermis is also increased in size. That's acanthosis. And then note at the tip of this black arrow I've shown here how in some places the dermis gets very close to the surface of the skin. The blood vessels in the dermis of patients with psoriasis can become dilated and tortuous. So when the blood vessels are very close to the surface of the skin, for example, in this portion at the tip of the arrow, sometimes a bit of the skin and scale can flake off, and that can lead to bleeding. That's called Auspitz sign, another classic finding in patients with psoriasis. And then finally, note also that in these places where the dermis gets near the surface of the skin, you can sometimes have neutrophils migrate outward, and that can lead to the formation of the Monro abscesses that we talked about in the last slide. There are several subtypes of psoriasis. The most common subtype is plaque psoriasis. That's what we've been talking about up until this point in this video. But you should be aware that there are other less common subtypes that look differently. These include guttate psoriasis, pustular psoriasis, erythrodermic psoriasis, and finally inverse psoriasis. You can read about all these subtypes if you wish. Psoriasis commonly involves the nails. Many patients with psoriasis develop nail pitting. There's an example of that shown on the screen here. You can see the pits in this person's nail. In addition, many patients with psoriasis develop onycholysis, which is separation of the nail from the nail bed. And then finally, about a third of patients who have psoriasis of the skin develop psoriatic arthritis. This is a form of seronegative spondyloarthritis, which I talk about in videos in the musculoskeletal section. It's more common in patients who have the nail finding, so a classic presentation of psoriatic arthritis is someone who has psoriasis with nail findings and then develops arthritis. That is a person who may have psoriatic arthritis. Let's talk about rosacea, which is a common skin disorder. About 3% of the population has rosacea. It's a problem that occurs in adults over 30 years old. You'll very commonly see this in older or elderly patients. People whose ancestors come from the Celtic region or Northern Europe are at the greatest risk, and also people who are light-skinned are at the greatest risk. Rosacea is an inflammatory skin condition. It is a form of dermatitis. The pathology is complex and poorly understood. People who develop rosacea develop chronic redness of the nose and cheeks, including they may develop papules and pustules. These can sometimes look similar to acne, but there are no comedones. In other words, there are no plugged seborrheic ducts. If you look at the bottom left side of the screen here, this is a man with rosacea. Notice the redness on the nose and the cheeks surrounding the nose. That is a classic appearance of rosacea. These people often look like they have a bright red nose like Rudolph the reindeer. You can see the same thing on the right side of the screen. Other features of rosacea are shown on this slide. Facial flushing means that the face becomes red and warm. This is common in people who have rosacea. Often it's triggered by some environmental stimuli, for example, cold or heat or the sun or certain types of drinks or food. Or a classic trigger is alcohol. Many people with rosacea, when they drink alcohol, their face will become red and warm. And finally, some people with rosacea, especially if it's long-standing and untreated, will develop what's known as phimosis rosacea. You don't see this much in the modern era, but this used to happen years ago. So recurrent episodes and chronic inflammation from rosacea would lead to skin hypertrophy and thickened skin. This would commonly occur on the nose, which was called rhinophyma, and this is a drawing of a man with rhinophyma, as I said before, usually something you don't see in the modern era. Next, let's talk about seborrheic keratosis. These are common benign tumors. Don't confuse these with actinic keratoses, which I talk about in the video on skin cancer. Those are pre-malignant lesions, but seborrheic keratoses are benign. These lesions are caused by a proliferation of immature keratinocytes, and it's high yield to remember this. This is the kind of thing they want you to know in step 1, is which cell type causes the problem. So what you've got happening here is a growth of immature keratinocytes. It's a benign, not malignant growth, but that causes these dark lesions that look like this one shown in the slide here. It occurs in older patients, usually more than 50 years of age. They tend to arise spontaneously, and they're very common on the trunk. When you do primary care clinic and you examine the skin of your older patients, you will often find one or more of these seborrheic keratoses on the trunk. A picture of some seborrheic keratoses are shown on the screen. This is a good example of one right here. They are flat and well demarcated. They are round or oval. They have a dark velvety surface, and they appear stuck on, almost like someone took something that was dark and stuck it to the skin. That's the classic description of a seborrheic keratosis. On biopsy, what you see is something like what's shown in the slide. First of all, you see dark cells that are similar to basal skin cells. You can see all these dark cells here. These are the immature keratinocytes that cause seborrheic keratosis. The other classic finding are cysts that are filled with keratin. These are called horn cysts. This is one right here at the tip of this arrow. Classic finding in seborrheic keratosis. There is a rare clinical finding that you should be familiar with for your board exams because it tends to come up in board questions. It's called the lesser Trellat sign. This is the explosive onset of multiple itchy seborrheic keratosis lesions. This is an example of what it looks like on the screen here. So you can imagine a patient who did not have any seborrheic keratoses who suddenly develops all of these lesions on his back. That is what the lesser Trellat sign looks like. It's probably caused by cytokines, and the high yield thing to know about this is it's associated with malignancies. Gastric adenocarcinoma is the most common. So a classic board question is a man who presents with the lesser Trellat sign and they ask you what to do next, and one of the things you should think about is looking for evidence of gastric adenocarcinoma. Next, let's talk about verrucae, which most people call warts. Warts are a cellular proliferation triggered by the human papillomavirus. There are many different types of warts. Those on the skin are the most common. These are called verruca vulgaris. If you don't know this, the word vulgaris means common, so anytime you see that, it usually means the common form of a disorder. Verruca plana are flat warts on the skin, and then finally condyloma acuminata are venereal warts. So verruca vulgaris or cutaneous warts are the most common manifestation of human papillomavirus infection. The virus is transmitted by contact, and for this reason, these warts are common on the hands because we tend to touch things with our hands, and sometimes we come in contact with the human papillomavirus. Once you have that virus in your skin, it leads to epidermal hyperplasia. That's what causes the warts. This is a picture of a person with a number of warts on their thumb, and you can see all these areas where the epidermis is undergoing hyperplasia. That's what is giving the appearance of the warts. If you biopsy one of these lesions, the classic finding, and the one you should know about for your boards, is koilocytosis. This means there is clearing of the cytoplasm or halos around the nucleus of the cell. So if you look at this picture on the screen here, we've got a nucleus here and all this white clearing around it. That is a classic feature indicating infection with the human papillomavirus. And that concludes our first video on skin disorders.